One of the key issues for families is, okay, if we have a successful shunt and we're able to drain the bladder and the urinary tract, get good lung growth for pulmonary function after birth, how do these kids do after they're born?
What was recognized in some of these boys that had valves is that they really didn't have the ability or the awareness that their bladder was full.
60% of these kids that were treated in utero were able to spontaneously void on their own, and the rest of them either required occasional use of a catheter to completely empty the bladder, or they were catheter dependent.
Long-term outcome studies that we have done has shown that most of those children that were prenatally treated have acceptable renal function, but 30% also have progressed to renal transplant.
These are children that don't have normal urinary tracts and will always be at risk of further kidney injury, either because of reflux or because they're much, much more at risk and susceptible to infections.
There are changes that can occur over time that unless you're really tracking them and following them, you may not recognize, which can then ultimately lead to damage to the kidneys.
He's at increased level of hurting his kidneys if he gets infections. He is on an antibiotic.
These babies may require long-term follow-up for their kidney function. Usually respiratory issues are more black and white at the time of birth.
Half of them have some type of respiratory symptoms long-term, low incidence of asthma. Most of them have a higher frequency of reactive airway disease, so they get colds and upper respiratory infections more often and commonly than other kids.
While that certainly can be a challenging time, most families and most children will report to us that they're doing well and they're adjusting and dealing with the challenges of daily life.
Michael now is 18 months old. He is running, no longer walks, he just runs.
If you looked at him today, you wouldn't know on the surface that there's anything wrong with the kid. I mean, he eats like a tank.
He's just a crazy high energy boy. He's really independent, but continues to be very, very happy. So to have been able to go through this really critical situation and come out on the other side as healthy as he is, he's just so fortunate.
We now have a whole cohort of what were unborn patients with a previously completely fatal diagnosis who have been helped by what we and others have done before birth.
The natural history of lower urinary tract obstructions is quite diverse.
We continue to learn, and now I think we have a much better perspective on things, understanding what happens in terms of how the kidneys are developing, what happens to the lungs.
For lower urinary tract obstruction, we can select which fetuses will benefit, and we can help them in most circumstances.
There are lower urinary tract obstructions that are associated with normal amniotic fluid volume, maybe due to an incomplete obstruction, and those at this point are not candidates for in utero intervention.
So one of the studies that's presently underway is to look at the natural history, the outcomes in these children that have obstructive uropathies but have normal amniotic fluid volume, to determine whether there might be benefits for intervening in those cases as well.
A clinical effort at the current time is to attempt before birth to directly treat posterior urethral valves.
Fetal cystoscopy, where we can actually look inside the bladder, try to identify the source of the obstruction and potentially treat it.
And then not have to leave a shunt in place afterwards.
I think the future is bright for families with this disorder.
The families at the Center for Fetal Diagnosis and Treatment really serve as the inspiration for each and every one of us.
That's what it's really all about. It's about the amazing families that teach us what we need to know to offer hope for future generations.